to go on and just talk a little bit about bleeding, which is probably the biggest risk factor for endoscopic necrosectomy. This is was the very first really study that had a long-term follow-up. This is back from 2009, before LAMS. This was really early on in our necrosectomy experience. I'll just point out that the bleeding complications was 14%. Now, in this study, bleeding was defined as requiring transfusion, and so that's a fairly big number. But I want to focus again that this is very early on, and I'll show you this picture here of some of the sizes of the vessels that you can run into. A vessel like this, I would tend not to want to treat endoscopically at all, and I think what we did with this patient and send that patient for prophylactic embolization before we went back into that cavity and started doing necrosectomy. Let's move on. Now, this study here is one that it's in print now. It was just published in GIE, and this is 536 necrosectomy procedures done at Thomas Jefferson. I think this was 160 patients, and the incidence of bleeding for all procedures was 5.2%, and the incidence of bleeding for all patients was 11.9%, so not too far off the 14% of that study 10 years ago. However, this was all bleeding, not only bleeding that required transfusion. And in fact, the vast minority of these patients were requiring transfusion. So what we found was that the risk factors for bleeding were certainly thrombocytopenia and cirrhosis, which are a risk factor for bleeding in all procedures. And then obviously the identification of a vessel within the cavity was the most strongest predictor of significant bleeding. And I just have this one diagram up here that shows you that there are connecting vessels between the splenic artery and the transverse pancreatic artery. And these are the ones that we are most concerned about because they have a tremendous source of arterial blood supply, and people can do poorly when these vessels actually are disrupted during the course of necrosectomy.